Good morning, plebes. Buenos dias. It's about 5:30 a.m. My car is completely frozen, and so we're just waiting for it to heat up. But yeah, it's gonna be a good day. Animo. Sweet. So I just arrived. It's about 5:45 a.m. I'm a little tired because I stayed up kind of later than I wanted to last night, kind of preparing for today's day, reading up on cases and stuff like that. And because the preceptor definitely expects me to be familiarized with the procedures we're going to do and also with the patients that I'm about to round on. So we'll see how it goes. First time pre-rounding, second time in the OR. The pericardium now. Pericardium is a fibrous sac which So I just got home. The time is around like 7:30 p.m. and it was an interesting case. Did a mitral valve repair using a robot, the Da Vinci device. The surgeon sits on like this big computer thing and manipulates using his hands and feet this robot to get into the atrium and do the repairs of the mitral valve. During this case, I got to throw in a few sutures and help with the closure of the initial incision, and also with one of the femoral lines that they put in the leg, and got to suture that. And yeah, so that's Monday effectively what we did today. 13 hours in the operating room. ¿Qué onda, plebes? Buenos dias. It is 5:40 a.m., which means I got up today at 5 a.m. On a Tuesday. We're back for more. We're back at the hospital. Just parked, about to go in. Today, I don't think we have any operating room cases, but we do have a big meeting at 6 a.m. I don't remember if this is the morbidity mortality meetings, which essentially just means evaluating cases that either went wrong or that just had complications, and to learn from them. But yeah, today's gonna be a good day. The only thing about today that I'm kind of nervous about is that I'll actually be on call for the first time, and so overnight tonight, if anything emergent comes in, anyone needs an emergent CABG or just emergent open heart surgery, I'll have to come in with the team. And so it's both exciting, nervous, all those things. But yeah, let's go do it, and I will fill you guys in if I get a chance to shoot inside or after. Animo, plebes. Today I actually didn't scrub into any cases. I actually spent the time with my preceptor on the floor, so managing essentially the cardiothoracic critical care unit. And so this is essentially managing all of the patients that have come out from surgery. So post-op patients and people that are recovering from a very intense operation and have a lot of lines, a lot of drips. So yeah, plebes, and what else? Today I am on call. So I have both of my fingers crossed that like I don't get called in, but I also want to get called in on something interesting, and so we'll see how it goes. Buenos dias, plebes. Today is Wednesday. It's 5:25 a.m. I got up at like 4:40 a.m. this morning, took a shower and head out the door. Good thing about last night, I did not get called in, which is really nice because I was really tired, and I'm still pretty tired. But the reason I'm here so early is because we have a patient to see, and so I'm going to see that patient and kind of prepare the pre-round presentation, and then around 6:45 today I'll be presenting that patient to the surgeons and kind of giving them an update about all the overnight events. And then today, as surgery goes, I think there's one surgery, but I'll tell you guys about that case at the end of the day.
So this is the left chest, this is the pleura, you can see the lung, that's the lung, these are the ribs. So the vessel is running somewhere here, which we'll be identifying and starting to harvest soon. So this is the left greater saphenous vein, which we harvested from the left lower extremity from there. Right now what we're gonna do, we are going to stop the heart. We are giving solution rich with potassium that will help us to stop the heart. Okay, you can see heart stopped. You can show the EKG if you want to. It's a flat line now. We are showing the anastomosis now, the left inferior mammary artery to left anterior descending coronary artery. So now what we are doing, we are giving warm blood to the heart so we can warm it up and get rid of the potassium. Okay, so heart's going to start beating now or fibrillating.
Yep.
Okay, you can see now these are the grafts. Can you see the grafts there? Yeah, this goes to the diagonal artery, this goes to the occlusal marginal behind the heart. Oh yeah, smoke.
Surgery, and it kind of just seems like when they're in there and they open up the heart, and it's kind of like working on a car. You're opening up the hood, and while you're there you're going to try to repair all of the things that need work, and so that's very much what they do here. I got complimented by my preceptor today on my presentation and just like how I carry myself, and so that was really something special, and something that I think I just appreciate, because I showed up the first week of when I was scheduled to be in the operating room kind of intimidated, and I wanted to rise to the expectations that this rotation has. Now, before I end this video, I do want to leave you guys with some tips to help you guys be, successful on your surgical rotation. Number one, prepare the night before. And because essentially every day as I was, scrubbing in and getting ready to go into the operating room, my preceptor would essentially ask me like, okay, can you tell me about this patient? What is their medical history? Number two is, if you're gonna be expected to pre-round and do physical exams on patients that are in like an ICU setting, definitely show up early. I found personally, just because I hadn't done it before, I needed a full hour. And so if pre-rounds start at 6:30 or 6:40 a.m., I found myself that I needed to be walking into the hospital at 5:30, because at least at UC Davis, some of the patients are on the complete opposite side of the hospital. And so it was almost like a 10-minute walk to get to the other side, to get up to the floor that I needed to be on, see the patient, do a physical exam, ask how they're doing, and then work my way back and be ready to present. Number 3, your preceptors don't expect you to like not take breaks, and they know that you don't have the stamina that they have because they've been doing this for years, right? And so kind of keep that in the back of your mind. Tip number 4, in regards to suturing, the expectation is that you're gonna be terrible at suturing. And if you're doing everything else right, like showing up on time, showing up early, being prepared, knowing about your cases, your preceptors are gonna be super open to letting you scrub in and help them close. And they're gonna be super patient with you as you're being the slowest suturer on the planet. And I think as far as technique goes, you just need to know 4 things and be familiar with them. But you should know number 1, a simple interrupted suture. Number 2, a running subcuticular suture. And then number 3, a one-handed surgical knot tie. And number 4, a 2-handed surgical knot tie, because that's usually used to like attach to suture in lines and hold things in place. And then tip number 5 goes back to what I was talking about, presenting on your patient, is really pay attention the first day that you get there, the way the residents present patients, and try to emulate that. If you want a outline that I kind of found on Reddit, some of the stuff that my preceptor gave me and just some of the things that I learned, I have an outline also attached at the end of this video. I guess another tip, we're doing more than 5 tips. You can get, I know previously for emergency medicine, I had bought this like fancy like notebook. I'm kind of like halfway through clinicals and we're balling on a budget. I went to Daiso and got this like nice little, this like drawing book for like $2. It's more than enough and it's like perfect. It fits in your pocket and it's just nice to have. I was always carrying this and a pen. But when you go and see your patients in the morning, you want to kind of have a little outline checklist of like what you're gonna ask the patient. That way you can just get in there and get out. And so kind of typically what I would do is I would write the bed number on here, the name of the patient, and then I would ask the patient, are you doing well? How's your pain? Do you feel like your pain medication is adequate? I would ask if they're urinating, if they've had any bowel movements, how they're tolerating fluids and food. And then I would go into the physical exam. And I would always do a cardio exam, a pulm exam, abdominal exam. And then you're gonna wanna make sure and check any incisions that they may have. So if they did like a sternotomy, like opening up the middle, you're gonna wanna make sure that that's looking clean, dry, and intact. Same thing, like if they have any groin, like a femoral line, and that was taken out and they have an incision there, you're gonna wanna check any cuts that essentially were made during the time that they're on the service. If they have chest tubes, you're gonna wanna check those and check the output and color of those chest tubes, and any drains as well, like if they have like a urinary catheter. And lastly, as you're walking out, check in with the nurse and ask if they need anything. And also if you don't have an idea of what to do for the plan, pro tip here, ask the nurses. Essentially come up to them and be like, hey, my name's Mario, I'm a PA student, I have no idea what I'm doing. What do we usually do around post-op day 3? Or what do we typically do? What do you expect that we're gonna do for this patient today? Literally